All right, let's jump right into this explainer. We're running a continuous clinical gauntlet today, decoding the true endpoints of resuscitation and really digging into the hemodynamics of shock.
First up, in patients with septic shock, which parameter typically increases due to severe peripheral vasodilation and systemic shunting? Is it A, systemic vascular resistance, B, mixed venous oxygen saturation, C, central venous pressure, or D, left ventricular end diastolic volume? You really got to think carefully here about what happens to the venous oxygen content when blood literally shunts right past the capillary beds. The correct answer is B. So here's the deal. Despite really poor tissue oxygen extraction at the cellular level, severe endothelial dysfunction and arteriolar dilation significantly tank the systemic vascular resistance. Because of this hyperdynamic state and all that regional shunting, the blood just bypasses the tissues. It returns to the heart with a characteristically high oxygen content. That gives you an elevated mixed venous oxygen saturation, usually greater than 70%. Now, all of the following are classic physiological features of neurogenic shock, except A, bradycardia, B, hypotension, C, reflex tachycardia, or D, warm, well-perfused extremities. Keep in mind, an injury at or above the T6 level fundamentally disrupts those descending sympathetic pathways. And the answer is C. This brilliantly illustrates what happens when sympathetic vasoconstrictor tone is lost. It leaves the parasympathetic vagal tone completely unopposed. Because of that, the heart just can't mount a compensatory reflex tachycardia, even when facing severe hypotension. Plus, that profound vasodilation makes the extremities feel warm and look pink, which is completely the opposite of the cool, clammy skin we're so used to seeing in other forms of shock. Which statement is true regarding the use of vasoactive medications in the resuscitation of septic shock? Your options are A, epinephrine is the absolute first line. B, norepinephrine acts primarily as an alpha-1 adrenergic agonist. C, vasopressin should be routinely titrated to high doses. Or D, phenylephrine is preferred because it causes significant reflex tachycardia. We really need to evaluate our pharmacologic options here and understand exactly how they manipulate systemic vascular resistance. E is the correct one. Norepinephrine is absolutely your first-line go-to, primarily because its potent alpha-1 activity actively constricts the peripheral vasculature. That increases systemic vascular resistance and mean arterial pressure. Plus, it's got this mild beta-1 activity that helps maintain cardiac output. It's just a much safer profile compared to, say, vasopressin, which we have to restrict to a fixed low dose to avoid mesenteric ischemia, or phenylephrine, a pure alpha agonist that actually induces reflex bradycardia, not tachycardia. During a massive crush injury, the release of intracellular contents triggers an intense systemic inflammation. Which endogenous molecule acts as a classic damage-associated molecular pattern, or DAMP? A, LPS, B, peptidoglycan, C, extracellular ATP and mitochondrial DNA, or D, IL-10. What exactly triggers the systemic inflammatory response from deep inside those necrotic muscle cells? The answer is C. Let's break down this distinction, because it's vital. ATP and mitochondrial DNA are endogenous DAMPs. They naturally live inside human cells and spill out during sterile trauma or cellular stress. On the flip side, LPS and peptidoglycans are exogenous PAMPs, pathogen-associated molecular patterns, meaning they come from bacterial cell walls. And IL-10? Well, that's just an anti-inflammatory cytokine. A 58-year-old male with a massive anterior wall MI presents with dyspnea, a blood pressure of 82/54, a heart rate of 112, and bilateral pulmonary edema. Which hemodynamic profile accurately represents his state? Think about the mechanics happening right now. What's going on with his cardiac output, his systemic resistance, and those pulmonary pressures? The answer is B. This profile perfectly maps out cardiogenic shock. That damaged left ventricle fundamentally drops the cardiac output. Because the heart just can't effectively eject blood, the pressure backs up into the lungs, severely elevating the pulmonary capillary wedge pressure, driving all that pulmonary edema. Then, in a desperate attempt to keep systemic perfusion going, the sympathetic nervous system kicks in, triggering peripheral vasoconstriction and heavily increasing systemic vascular resistance. What is the primary physiological rationale for establishing a mean arterial pressure target of 65 millimeters of mercury or higher during early shock resuscitation? Is it to maximize blood flow velocity, ensure autoregulation of critical organs, prevent respiratory alkalosis, or minimize fluid overload risk? Why do we obsess so much over this specific blood pressure threshold? Yep, it's B. Critical capillary beds in your vital organs. Think the brain, the kidneys, the heart. They absolutely rely on an intrinsic pressure-dependent process called autoregulation to keep blood flow steady. If you drop below roughly 60 to 65 millimeters of mercury, this intrinsic autoregulation just completely fails. That leads to a direct, linear decline in perfusion, rapidly precipitating acute ischemic organ failure. Following a high-speed MVA with right-sided rib fractures, your hypotensive patient doesn't respond to 2 liters of fluids. What signs indicate obstructive shock from a right-sided tension pneumothorax? Clinical examination is everything en route to the ED. We have to clearly distinguish obstructive shock from hypovolemia or cardiac tamponade. The answer is A. This presentation sharply contrasts with Beck's triad, which points to cardiac tamponade. A right-sided tension pneumothorax gives you respiratory distress, hypotension, diminished breath sounds on the right, hyperresonance, and jugular venous distension. Crucially, that massive pressure buildup physically pushes mediastinal structures away from the injury, creating that classic leftward contralateral tracheal deviation. A 17-year-old woman in a diving accident is hypotensive, bradycardic, and her cool extremities do not withdraw to stimuli. What is the most likely cause of her hypotension? Is it inadequate blood volume, an inherent lack of venous return, loss of vasoconstrictor impulses, or systemic endotoxin release? The correct response is C. The trauma to the cervical region completely disrupts sympathetic autonomic regulation. This directly causes a massive loss of vasomotor tone to the peripheral arterial beds. That loss of vasoconstrictor impulses massively expands vascular capacitance. Blood just pools heavily down in the lower systemic reservoir, dropping the venous return and fundamentally tanking the cardiac output. What actually defines adequate resuscitation in the setting of shock? Take a second to read through these options. Is it just the resolution of hypotension, or is it something occurring much deeper, on a microscopic cellular level? This really challenges that basic instinct to just stop once the vital signs look normal on the monitor. The correct answer is B. Just normalizing blood pressure and heart rate? That's not enough? If you stop there, you're often leaving patients in a dangerous state of compensated shock with severe occult hypoperfusion. The true endpoints of resuscitation are only met when that systemic tissue oxygen debt is fully repaid, the microvascular tissue acidosis is corrected, and standard cellular aerobic metabolism is thoroughly restored. If you don't hit those marks, you're practically inviting future multi-organ failure. Base deficit. Does it A. quantify the magnitude of the perfusion deficit? B. represent status but not mortality risk? C. indicate a hospital-acquired infection? Or D, provide no additional info when serum lactates are present? How do we actually quantify that systemic perfusion deficit we were just talking about? A is correct. Base deficit accurately quantifies the overall magnitude of the systemic perfusion deficit, and it is a shockingly strong predictor of death. Stratified into mild, moderate, and severe, hitting a severe threshold of greater than 15 millimoles per liter carries a massive 70% expected mortality rate. Seeing that immediately dictates drastically higher requirements for volume loading and emergency blood transfusions. So I'll leave you with this thought. If normal vital signs frequently lie and mask occult hypoperfusion, how confident are you that your stable patient sitting in the bay right now isn't silently accumulating a fatal cellular oxygen debt?